work. Hello, I'm Thomas Roederer. I'm with Epicentre as an epidemiologist for the past 15 years. It's the first time that I worked in a population in nursing homes, and this is a study that we conducted with in nursing homes, in EHPAD, as they are called in France, with the residents and with the healthcare professionals during the first wave of COVID pandemic, 2020 and the beginning of 2021. So these EHPADs, or nursing homes, in fact, accommodate people according to their level of autonomy. This autonomy score is called GIR, from 1 to 6, for people who are the most autonomous. The first wave of COVID was quite deadly for these people. 44% of all deaths in France and 5% of all residents due to residents' vulnerability. And despite strong preventive measures, isolated in rooms, these people could not go out. Unfortunately, the toll was very high. Now, during the second wave, MSF targeted two regions, Île-de-France and the southwestern part of France, to identify where we could be the most useful. We wanted to support people in the nursing homes, providing them with support in terms of organization or support by delegating healthcare professionals and doctors. And we also worked with the healthcare professionals. In December 2020, MSF teams turned to Epicentre because they had a feeling that people in nursing homes suffered quite a significant negative impact from the COVID pandemic, and also due to the preventive measures that were in place. So MSF was involved in the southeastern part of France, PACA and Occitania. This is where these two regions are in France. With so 47 nursing homes where MSF operated during this period between November and January. And now the epidemiologists in the field conducted interviews with residents and also with the and a sociologist worked with MSF teams to talk to the healthcare professionals and the management of these nursing homes. For quantitative data, we got data from 22 nursing homes. Then the epidemiologists then designed a retrospective list of patients who tested positive for COVID. And there was also a diagnosis of comorbidity, and among which there's a sudden onset of deterioration after people receive a shock. And then we described the data and we constructed models, univariate and then multivariate survivorship models. And we also identified factors that could that influenced the case fatality ratio associated with COVID. Qualitatively, we focused on 4 nursing homes. The sociologist worked in these nursing homes, and she conducted interviews with a sample of residents, healthcare professionals, managers, and representatives of the public health regional agencies. Now, I don't want to give you too many details, but in the 22 nursing homes where MSF was involved, the ratio of healthcare professional per patient was not sufficient, 0.7. And during the second wave, there was also a very high level of impact among residents, 33% for staff, 66% for residents with a very high case fatality ratio, 19%. We also designed a model to identify the probability for a nursing home resident to die from COVID, and as you can see on the curves, to be a male patient, to be very dependent, to present with a rapid deterioration of symptoms, or the lack of a coordinating doctor in the nursing home were factors strongly associated with case fatality rate. Now, the factors associated with an increased risk of dying was being a man, being also a victim of this syndrome, of this rapid deterioration syndrome. And in green, the factors associated with fewer risks, such as the level of autonomy, the presence of a doctor in the nursing home. And so these are factors that decrease the risk of dying or at the time. The qualitative survey covered 3 months between January and March 2021. The sociologists could interview 7 residents, 36 HCPs and managers, and 2 regional agency employees. This ties in quite nicely with the quantitative analysis findings. Interviews highlighted the fact that these nursing homes are understaffed, and that the situation was worsened because of the pandemic. And all that was said, in fact, highlighted the fact that these preventive measures, in fact, were detrimental for the quality of life of residents. Our survey highlighted the isolation, medical isolation of nursing homes and the healthcare professionals in nursing homes. Some managers, one director said that it is really very regrettable that there was no permanent coordinating physician. With the crisis, the isolation and the understaffing of nursing homes worsened. A psychologist said, my fellow caregivers are telling me I'm not happy with my job, I can't work well, or a nurse telling us about the very long days and the very heavy burden of work, the workload in particular due to some colleagues being sick, and one nursing home manager saying that, well, a lot of people are just quitting. They don't want to go on with their jobs anymore. But above all, the management of crisis in the nursing homes was done just like in the hospitals, with a feeling of no planning ahead, no roadmap, and one employee of a regional health agency tells of the lack of clear instructions and the shortage of masks during the first wave. And when instructions were given, overnight, healthcare professionals were required to stop touching these residents in nursing homes. A psychologist told us that she really had to give up on her job so as to help the teams to apply the protocols and the preventive measures. Or another healthcare professional wondering about the relevance of isolating residents away in their rooms, like if they were put in jail. So in this exceptional crisis, how MSF was perceived, one manager said that it is really a pity that they had to rely on a humanitarian NGO, though they really appreciated the efficacy of MSF teams. A coordinating physician was really very much satisfied with the possibility to talk to a colleague, a doctor, about this almost unknown disease, or a nurse saying that with MSF, thanks to MSF, it is possible to reassure the teams and improve the organization. What we can say is that after the first wave, there is a big trauma, and that all residents saw their condition deteriorate, with a lot of these syndromes of just slipping away and just giving up. And or an employee of a regional health agency saying that these preventive measures were not tenable in the long run, and that people couldn't be isolated until they were going to die. These preventive measures had appalling consequences for residents, and a lot of these residents they say that they were really very depressed. They found it very, very difficult to not being able to see their relatives, their loved ones, that they felt prevented from seeing their families, and that their rights had not been respected. And it is very difficult. Some psychologist was really still very shocked about the number of body bags they had to use, or witnessing 18 deaths in a row, and health agency colleagues saying that it was absolutely appalling to have to isolate people, and that these people anyway were dying all the same, and that in these nursing homes anyway people die all the time, whether they die from COVID or from something else. Now, with this action, MSF did something quite unheard of, both in scope and in terms of the medical situation, circumstances. We could see with a survey that it is really quite problematic when the nursing home could not control the epidemic. Do you then implement preventive measures and then run the risk of having residents feeling depressed and slipping away, or lift these preventive measures and run the risk of having people die of COVID? But all nursing homes personnel had to make decisions that were contrary to their ethics and principles. We came up with a number of proposals forwarded to the Ministry of Health. Some recommendations to tackle the next epidemic, like alleviating isolation measures or avoiding banning visits for residents. And we also highlighted the chronic structural problems of this of nursing homes, asking for demanding more humanity and more support for these structures. Of course, we cannot say that what we saw is truly representative of everything that goes on in other nursing homes. However, one can say that similar observations were reported from the United States or England or Spain or Belgium, So everywhere, in every country, the way these people and the end of life is dealt with should be revisited. I would like to thank our colleagues and the healthcare professionals in nursing homes, and also the residents and the managers of the 4 EHPADs, of the 4 nursing homes, who give us some of their time.